Hello, guys. Good day to everyone. So, today we are going to talk about congenital disorders of the skeletal system. So, this is our first topic for orthopedic nursing. So, one of the diseases or congenital disorders in ortho would be this one, the developmental dysplasia of the hip. It was formerly known as congenital hip dysplasia. So, description of this, there is an imperfect development of the hip, which involves the femoral head, the acetabulum, which is the socket, or both, the ball. The ball is the femoral head, and the acetabulum is the socket. Take note, the ones who are afflicted with this are female. 60% of them are females. There are three classifications of this disorder. One is acetabular, which is the mildest form since the femoral head still remains inside the socket, which is the acetabulum. That's why it's known as acetabular. Second one is subluxation. It's the most common form. Take note, the most common form of this disorder. The femoral head is partially displaced here, while this location, the femoral head is no longer, it's not in contact with the acetabulum, with the socket. So it's outside the socket now, and it is displaced either, it's displaced posteriorly and superiorly. So here are the illustrations of the severity of the developmental dysplasia of the hip. Normal, or for the acetabular type, it still remains in there in the acetabulum, while for subluxation, it's somehow displaced. But for this location, as you can see with this illustration here, it is already out of the socket, out of the acetabulum. So there are several forms of this. Causes. Genetics play a strong role in the incidence of hip dysplasia. So the risk of hip dislocation at birth is approximately 1 in 1,000. So in 1,000 births, one of those infants will be afflicted with developmental dysplasia of the hip. So if a parent has experienced hip dysplasia during childhood, the risk of his or her own child developing this would increase by 12%. So if you have a parent who has this when he or she was a child, you will have a 12% chance of having this compared to a parent with no history of the condition. And a child who has a sibling that has this condition has a 6% chance higher of developing this condition. Even among children who have no hereditary link, there is a greater risk for all firstborn. So all firstborns, like me, I'm a firstborn, there is a risk for the development of this TDAH. Other pregnancy and birth influences include molding abnormalities, head tilt, or torticollis. This is the turning of the front of the foot, turning in, metatarsus adductus, which is often the result of being constrained in a uterus that is too small. So let's say, for example, the mother is just a teenager, and if the uterus is too small for growth to occur, either torticollis, we will have a separate discussion for this for Wry Neck later on, or the turning in of the foot, metatarsus adductus, can result, and even hip dysplasia. If these conditions are present, medical professionals should also be on the lookout for the presence of hip dysplasia. So these are other conditions that can occur. because of a small uterus, most likely for teenage mothers. For breech birth, this is where the baby emerges from the birth canal, buttocks first. So if the buttocks or the lower extremities of the infant comes first, um, the child is 10 times more likely to develop hip dysplasia than a child born head first. So for mothers who have, or for infants rather, for fetuses who have breech position, they are 10 times more at risk to develop DDH. Other factors, hip dysplasia is more common in girls than in boys, like what I've mentioned earlier. And this affects the left hip than the right. And about 80% of cases follow this pattern. So 80% involve hip dysplasia of the left hip. But this condition, however, can be present in both. It can be bilateral, but in most cases, they are unilateral. Unilateral meaning one-sided. Clinical findings or the clinical manifestations. Number one, limited abduction of the leg on the affected side. So the infant will have a hard time abducting, moving that limb away from the midline. So when we say abduction, it's moving of the limb away from the midline. So they will have a hard time doing that. And as you can see, there will be, if you check the buttocks of the infant, there is asymmetry of the gluteal, popliteal, and thigh folds like this one. So for a child who has DDH, you will see that there is asymmetry of the buttocks or the gluteal folds, the popliteal folds, as you can see there, and the thigh folds. And when we attempt to abduct and externally rotate the hip on the affected side, we are going to hear an audible click. You will hear a clicking sound. This is known as the Ortolani sign. Ortolani test is when we do this to the child who has DDH. Ortolani sign is the description or the clicking sound that you hear when we abduct and externally rotate the hip of the affected side. Next would be the Galeazzi's test, or also known as Alice sign. This is used to assess for hip dislocation. And what we do here, this is primarily done to test for DDH. It is performed by flexing the infant's knees when they are lying down so that the feet will touch the surface of the bed, for example, or of the examination table, and the ankles touch the buttocks. Now, if the nurse or the physician sees that the knees are also, or there is a symmetry of the knees, that is the Galeazzi sign or test or Alice sign. So if one knee is higher than the other, that is, we are going to say that the patient is positive for the Galeazzi test. So if one knee is higher than the other, he or she is positive for the Galeazzi test, or the Alice sign. And for the fifth one, of course, you can see there's shortening of the femur of the affected side based on this test that we are going to do on the infant. So this one, you can see here, one knee is higher than the other. One femur is higher or is longer than the other. So there's a difference in the knee height. Therapeutic interventions. One is directed toward enlarging and deepening the acetabulum by placing the head of the femur within the acetabulum and applying constant pressure. So what the doctors are going to do, the pediatric doctors or pediatric or ortho, they are going to place or make sure that the head of the femur is within the acetabulum. So the pediatric orthopedics is going to apply constant pressure to make sure that the head of the femur is within the socket or the acetabulum. And they will correctly position it with the legs slightly flexed and abducted. In order to apply these constant pressure, the orthopedics or the pediatric ortho is going to place this on the infant. We have the Pavlik harness or the short leg hip spica cast. So any of these can be applied to make sure that the legs, as you can see here, they are slightly flexed and they are also abducted. At the same time, the pressure is within the acetabulum. The head of the femur is within the acetabulum here. But if these two are unsuccessful, the next thing that the orthopedic surgeon is going to do is to do surgical intervention through open reduction with casting. So they're going to open up the hip, and usually this is done for children between 18 months and 2 years who have a new diagnosis of dysplastic hip or in cases in which a prior closed reduction of the hip was unsuccessful. Like what I've told you, if the Pavlik harness or the spica cast or a brace is unsuccessful, surgical intervention is going to be done. So the doctors, the orthopedic surgeon, they're going to make sure that the head of the femur will be inside the socket. They're going to incise some ligaments, some muscles, in order to make sure that the head is within the acetabulum. Nursing management. If the patient is placed in a cast like the hip spica cast, we limit the risk for hypostatic pneumonia caused by enforced immobility. Change the position frequently as well in order to prevent hypostatic pneumonia. Raise the head of the mattress or the crib rather than the head in order to prevent neck flexion, because that would also be painful for the child if the head of the child is the one that is elevated. Even for us, if we flex our neck for a long period of time, that would be very painful. We also are going to teach patient or parents postural drainage or exercises to increase lung expansion, such as blowing bubbles. So that would be an appropriate type of lung expansion exercise in order for the child to, or for the lungs rather, to expand, since they will or children will enjoy blowing of bubbles. And teach also parents to use the force of gravity in order to drain the secretions from the child. So every now and then, the child may be placed on a Trendelenburg position in order to drain any secretions from their lungs. Letter C, we need to encourage patients or parents to notify healthcare provider immediately if any congestion or cough develops, because that is already a sign of hypostatic pneumonia. So we are preventing that from happening because of prolonged immobility brought about by the cast. And since there is a cast, we need to maintain skin integrity. For the first one, we need to assess circulation to the toes. We will need to check fetal pulses, signs of blanching, if there is paleness of the feet. We need to check those. Maybe the hip spica cast has been applied too tight on the patient's hips, and we need to prevent small toys or food from entering the cast because that will contribute to the discomfort that will be felt by the child. We also need to teach parents any signs of infection. If the parent, or if we are going to advise the parent, if they have smelled any kind of odor from the cast, they need to report that immediately because that is already a sign of infection. And we need to protect the cast edges, most specifically the ones that are below the hips, because they can cause injury. They can cause cuts or whatsoever on the skin of the patient. So we need to apply adhesive tape or waterproof material, especially those around the perineum, to prevent cuts from happening. We also are going to advise the parents to use disposable diapers with plastic lining to minimize soiling by feces and urine. As you can see here from this illustration, the hip spica cast has an opening for the perineum in order for urination and bowel movement to occur. And plastic lining must be placed around the edges of the cast to prevent it from being soiled by feces and urine. We also need to prevent constipation. We need to teach the parents to observe the child for straining on defecation, and of course to increase fluids and high fiber foods for the child in order to prevent straining during defecation. Number four, we need to encourage intake of nutritious foods appropriate for activity level. So we need to provide small, frequent meals because of the inflexibility of the cast around the waist. Sometimes the orthopedic surgeon will allow a window to be made over the abdominal area because children or infants are usually, or they usually have a rotund or round abdomen. And sometimes if they are full, it becomes globular. So to allow for expansion of the abdomen during after meals, a window on the cast is going to be done by the orthopedic surgeon. We also need to teach parents to adjust the calorie intake because less energy expenditure can lead to obesity. So since they are immobile, maybe we need to make certain adjustments on the diet of the child. And we need to move and position safely when in spica cast. So we're going to use a wagon or a stroller with a back flat or a mechanics creeper for transportation for the child. So if we are going to uh, bring the child from the room to the living room, just use the stroller. Or protect the child as well from falling when being positioned. So you need to monitor for the child as well on the bed. Sometimes there's a tendency for children to be um, to have that vigorous activity or whatsoever, they can fall from the bed just with the use of their hands alone. Children at that age can be very curious, so you need to protect them from falls. Avoid also using bars between legs of cast for lifting. Two people may be needed to provide adequate body support when moving, especially if the child is an older child. But for an infant, there's no need. Only a single person um, may be used for lifting the child. Use specially designed car restraint system for transportation in motor vehicles because most of the car seats for children are in an upright position, so they may need something that, or a car seat wherein the infant's back is flat on it. And we need to meet the emotional needs as well. Use touch as much as possible. Small children can be picked up and cuddle, most especially for infants. Sometimes infants, they cry because they want to be held by their caregiver, by their parents. Or we need to stimulate and provide play activities which is appropriate for the age. Number seven, provide parents with help and support. We need to reinforce teaching with written instructions, schedule home visits with telephone or email counseling available. Stress the need for follow-up care because treatment may be prolonged since the child has a cast that can last for several months. And we need to prepare parents for application of abduction brace after cast has been removed. So we need to teach the parents how to apply that to the child. So that's it for DDH. Now we go to clubfoot or Talipes equinovarus. That's the Latin name of clubfoot. Description. There is a bone deformity here and malposition of the foot. As you can see from this illustration, the foot is turned inward with soft tissue contracture. The foot is twisted out of alignment and also it may be misshapen. The Talipes equinovarus is the most common type wherein the foot is fixed in a plantar flexion downward and it is deviated medially, like you can see here. It's deviated towards the middle or towards the midline. The cause, again, it's mainly unknown, like the other diseases. And genetic factors are believed to play a major role, and some specific gene changes have been associated with it, but this is not yet well understood. It appears to be passed down through families, and it is not caused by any position or fetal positions inside the uterus. So primarily the cause is idiopathic. Clinical manifestations. You can see the deformity apparent at birth. So it will become very obvious once the infant has been delivered. And classification would be the following: rigid or flexible. So it's either rigid or stiff, or you can flex it. And mild, positional. It may correct spontaneously once the patient grows older and may require passive exercise or serial casting. Syndromic, this is associated with other congenital anomalies. So if there are any other congenital anomalies that are present. And congenital, it has a wide range of rigidity and prognosis as well. Therapeutic interventions. The treatment of this is going to be started during the newborn period. And once treatment is done during the newborn period, usually it is most successful because delay causes abnormal development of the leg muscles and bones with shortening of the tendons. So the doctors will avoid the delay of the treatment. They will treat it as early as possible. Non-surgical treatment is gentle, repeated manipulation of the foot with casting. So they're going to apply casts, which will be done every few days for 1 to 2 weeks, then at 1 to 2 week interval. So like this one, stage 1 for the first cast, it will be applied for 6 to 7 days. The second cast will be applied again, and so on until the fifth cast is going to be applied until the deformity is corrected. So this is done over a 4 to 6 week period. If the non-surgical treatment is not effective, like the casting that I've mentioned earlier, surgical treatment is going to be done, wherein the doctors are going to release the tightened ligaments and the tendons are going to be lengthened or transplanted. So that is what they're going to do. They're going to manipulate the ligaments and the tendons of the infant in order to correct the clubfoot. Follow-up care is to emphasize muscle re-education by manipulation and correct walking once the child grows older and is old enough to walk. Corrective shoes may be used by the child, so it may have a hole and heel lifts on lateral border to maintain position, and shoes must be maintained in good repair. And extended orthopedic supervision tendency to recur. There's a tendency for this to recur in patients. It is considered cured when the patient is able to wear regular shoes and they can walk correctly. So this is the surgical procedure wherein they cut off certain ligaments, they place or they elongate the tendons of the child. These are the foot braces or the shoes that are intended for infants who have clubfoot once casting has been done. Nursing care of children with clubfoot. We provide care associated with casting. Like what I've mentioned earlier, in casting, we need to monitor the patient's neurovascular status of the affected extremities, such as the color, skin, temperature, the capillary refill. It shouldn't be more than 2 seconds for the capillary refill. It should be less than 2 seconds. And for the toe movement as well. Temperature should be normal. It shouldn't be cold because the toes are cold, then there may be a problem with the cast. It might be too tight. Check also the cast for weakness and wear, especially if the child is allowed weight bearing. But since the child is a young infant, most probably they won't be bearing any weight on the cast. Teach parents as well as to assess neurovascular assessment of the affected extremities, the care of the cast, and special shoes. They are going to bathe the infant. They're going to wrap the cast with plastic in order for the cast not to be soiled by water because the water can degrade the cast. Emphasize also the need for follow-up, which may be prolonged depending on the type of clubfoot that or the severity of the clubfoot that the infant has. Next, we have Wry Neck or Torticollis. The description of this is Wry Neck or Torticollis is a painful twisted or tilted neck. So the neck looks like this. So the top of the head generally tilts to one side while the chin tilts to the other side. This condition can be congenital or acquired. It can also be the result of damage to the neck muscles or blood supply. Wry neck sometimes goes away without treatment, most especially if it is present during adulthood. However, there can be a chance of relapse. Wry neck or chronic wry neck can cause debilitating pain and difficulty performing daily tasks. Fortunately, medications and therapies can relieve pain and stiffness. So sometimes if the patient has chronic wry neck, they may experience pain. And there will be medications that will be given to them in order for them to be relieved from the stiffness and pain. Surgery is also used to correct the condition. Treatment is most successful if it has been started early. And this is most especially true if the patients are children. Causes of wry neck, this can be inherited and it can develop in the womb, like what I've mentioned earlier, most especially if the mother is 18. So because of the very small uterus, tendency is for the fetus's neck or head to be tilted to one side or the other. And it can also be due to damage to the muscles or blood supply to the neck. Anyone can develop wry neck after a muscle or nervous system injury. However, most of the time, the cause of wry neck is, again, unknown. It's idiopathic. So it's if that wry neck or if the cause of wry neck is unknown, it's known as or it's referred to as idiopathic torticollis. Types. We have the temporary torticollis. This is a type of wry neck that usually disappears after 1 or 2 days. It can be due to swollen lymph nodes, ear infection, a cold, or injury to the neck and head that can cause swelling. So if you have been on a sideline position for a long time and you've been using um, pillows, high pillows for your head, this can also cause this. Fixed torticollis is also called acute torticollis or permanent torticollis. It's usually due to a problem with the muscular or bone structure. So there's a problem with the muscles of the neck or the cervical bones. Muscular torticollis is the most common type of fixed torticollis. It results from scarring or tight muscles on one side of the neck. Scarring may be brought about by injury to that side of the neck. Klippel-Feil syndrome. This is a rare congenital form of wry neck. It occurs when the bones in the baby's neck form incorrectly, notably due to two neck vertebrae being fused together. Children born with this condition may have difficulty with hearing and vision. So this is an example of Klippel-Feil syndrome. I had a student who has this kind of condition before in the other school. So somehow their head is tilted to one side, and as you can see here, they have a shorter neck and a low neckline. And that student of mine before, his head is also tilted to one side. Unlike this from the picture, his head is slightly tilted to one side. That previous student of mine, it's really his head is really tilted to the left side, like this. Cervical dystonia. This rare disorder is sometimes referred to as spasmodic torticollis. So it causes neck muscles to contract in spasms. And if you have this cervical dystonia, the head twists or turns painfully to one side. It may also tilt forward or backward. This can go away without treatment, but there is a risk of recurrence. This kind of wry neck can happen to anyone, but they are more common to this age group, 40 to 60 years old, and it's more common in women than in men. So this type of wry neck cervical dystonia is common in the middle age, 40 to 60, and in women. Clinical manifestations of wry neck. Wry neck or symptoms of wry neck may begin slowly and they can worsen over time. The most common symptoms are inability to move the head normally, of course, since it's tilted to one side, neck pain or stiffness. There's also a headache and having one shoulder higher than the other, like my former student. The neck muscles are swollen, so you can see that they are edematous, and the chin is tilted to one side as well. The faces of children with congenital wry neck may appear flattened and unbalanced. They also may have motor skill delays or difficulty with hearing and vision. Like my previous student, he can only hear on one side because somehow his head seems like it's stuck to his shoulder for that student of mine. Therapeutic management, currently there's no way to prevent wry neck. However, getting treatment quickly can keep it from becoming worse. You can improve congenital forms of wry neck by stretching the neck muscles. If started within a few months of birth, it can be very successful, like for Clubfoot. So it must be done once the baby has been delivered. If this or other treatments don't work, surgery can sometimes correct the problem. Treatment for wry neck, the temporary ones, would be by applying heat, especially if there is pain, or massage to deal with the stiffness. Physical therapy or chiropractic care can also be done. So we are going to refer them to physical therapists because they are skilled enough to do massages on the neck that is affected in order to correct them. Traction can also be done. Stretching exercises of the neck as well, and neck braces can be placed in order to avoid the head from being tilted to one side. Surgical management. So they are going to fuse the abnormal vertebrae that are affected, or they are going to unfuse them, since some of the vertebrae are also fused together. They are also going to lengthen the neck muscles that are involved and cut the nerves or muscles that are supplying the affected side of the neck. Doctors can also use deep brain stimulation to interrupt nerve signals. This is only used in the most severe form of cervical dystonia, because constant nerve impulses to the neck muscles can cause muscle rigidity, leading now to wry neck. So they can use this to prevent nerve impulses from going through the neck muscles. Medications that we can administer with the muscle relaxants, most especially if it's a temporary form, in order to relieve the stiffness. And there are also, if there are tremors present in wry neck, medications that are used to treat the tremors in Parkinson's disease can also relieve these tremors or can relieve the stiffness of the wry neck as well. They stand, I have an acronym for this known as the capables. These are drug medications that are used to control the tremors seen in patients with Parkinson's disease. We have cogentin and carbidopa. Letter C. The first A is artane. Artane. The letter P is parlodel. Parlodel. The next letter A is akinaton. Akinaton. And then letter B, Benadryl, which is an allergy medication. It can also be used to treat tremors in Parkinson's disease. So that's Benadryl. Letter L, levodopa. That's levodopa. Letter E is entacapone. And letter S is Symmetra. So those are the capables. Drugs that are used to treat Parkinson's disease that can also be used to treat wry neck. Botox or botulinum toxin injections can be used as a treated as well, and it will be repeated every few months. So Botox is also used for this. And pain medications if the patient is experiencing pain from wry neck. Nursing management, we need to teach the patient ways on how to relieve the pain, such as applying heat and taking over-the-counter analgesics. Several of them with mefenamic acid, ibuprofen, aspirin, the COX medications such as celecoxib. And we also need to advise the client on how to use the neck brace and how to apply it. Assist also in the pre-operative care of the patient who will undergo neck surgery. So we need to know the pre-op, intra-op, and post-op nursing management for patients. We will teach you that in a different concept during peri-operative nursing, and also allay the anxiety of parents who have children with the genetic form of Torticollis. Next, now we go to muscular dystrophy. In muscular dystrophy, this is a group of diseases that causes progressive. When you say progressive, it worsens as time goes by. So progressive weakness and loss of muscle mass. In muscular dystrophy, abnormal genes Mutations interfere with the production of proteins needed to form a healthy muscle. So it's more genetic. And there are many kinds of muscular dystrophy. Symptoms of the most common variety begin in childhood, and they are more common in boys, in males this time. Other types don't surface until adulthood. There is no cure for muscular dystrophy, but medications and therapy can help manage symptoms and slow the course of the disease. So take note, there's no cure for this since this one is progressive. Cause. There are certain genes that are involved in making protein that protect muscle fibers. Muscular dystrophy occurs when one of these genes are or is defective. Each form of muscular dystrophy is caused by a genetic mutation particular to that type of disease, and mostly these mutations are inherited. So, in short, the cause is genetic. It is hereditary. Risk factors. They occur in both sexes in all ages and races, but the most common variety, the Duchenne, they usually occur in young boys. And people with a family history of muscular dystrophy are at higher risk of developing this disease or passing it to their children. So, like what I've said earlier, you have it's genetic. If you have a parent who has muscular dystrophy, there's a high chance for you to have it as well. So now we go to the types of muscular dystrophy. We have, we'll get to this since we have different clinical manifestations of muscular dystrophy. The Duchenne type muscular dystrophy. This is the most common form. Although girls can be carrier and mildly affected, they are more common in boys. Signs and symptoms which typically appear in early childhood might include frequent falls. So they are always falling out of the bed. There's difficulty rising from a lying or sitting position. There's trouble running and jumping. Waddling gait. So waddling gait, they walk like a duck. That's how the gait of a person with muscular dystrophy has. They walk like a duck or a penguin. That's waddling gait. Walking on the toes as well, or there are large calf muscles. Muscle pain and stiffness is also felt, and there may also be learning disabilities from this patient. And delayed growth, of course. So they will appear shorter than children of their own age. So the affective muscles are, as you can see from this illustration here for the Duchenne and Becker types, are the upper portions of the arms and the shoulders, and from the thighs going down to the knees. So the Becker muscular dystrophy, they're similar. Signs and symptoms are similar to that of the Duchenne, but they are milder and they progress more slowly. Symptoms generally appear or begin in the teens, but may not occur until the mid-20s or later. So it has the same site of Duchenne, which are the arms, shoulders, and the thighs. Other types, the myotonic. This characterized by inability to relax muscles following contractions. Facial and neck muscles are usually the first ones to be affected. And people with this form typically have a long, thin faces, drooping eyelids, and swan-like necks. So they have elongated necks. So that is the myotonic type. We have the fascioscapulohumeral type. The muscular weakness typically appears in the face, hip, and shoulders, as you can see here. The face, the hips, and the shoulders. Even the back of the legs. Shoulder blades might stick out like wings when arms are raised. So if they raise their arms, you can see that their shoulder blades are very prominent. Onset usually occurs in the teenage years, but can begin in childhood or as late as 50 years of age. Congenital, this type affects both boys and girls and is apparent at birth or before the age of 2. Some forms progress slowly and can cause only mild disability, while others progress rapidly and cause severe impairment. So that's the congenital type if it's present at birth. Limb girdle. The hip and the shoulder muscles are the ones that are usually affected first, as you can see here. That's the limb girdle type. And people with this type of muscular dystrophy might have difficulty lifting the front part of their foot and so they might trip frequently. Onset is usually in childhood or the teenage years for the limb girdle type. Complications of this, they will have trouble walking, of course. They will eventually use or need a wheelchair. They will also have trouble using their arms. So daily activities can become burdensome, difficult for them because the muscles of the arms and shoulder are usually affected. Shortening of the muscles or tendons around the joints or contractures can occur, and this will further limit their movement, their mobility. Breathing problems can occur. This is one of the fatal complications because progressive weakness can affect the muscles associated with breathing, such as the diaphragm, the internal and external intercostal muscles. So people with muscular dystrophy might eventually need to use a breathing assistance device later on. Ventilator, initially at night, but possibly during also the day. So once it progresses, the end point will be this, breathing problems. Curved spine or scoliosis. So weakened muscles might be unable to hold the spine straight. So later on, this will lead to the development of scoliosis. Heart problems can occur. So muscular dystrophy can reduce the efficiency of the heart muscles as well. And swallowing problems. So if the muscles that are associated with swallowing are also affected, nutritional problems and aspiration pneumonia can develop. So it's feeding tubes will be an option later on once it progresses to this. So it's really, really difficult to live a life with muscular dystrophy because it can affect your eating, your breathing, even your the heart can also be affected. So it's difficult to have this kind of disease. Diagnosis is to enzyme tests. They are going to check for damaged muscles because damaged muscles releases enzymes such as creatine kinase into the blood. In a person who hasn't had a traumatic injury, high blood levels of CK indicates a muscle disease. So if CK is increased, but there is no traumatic injury to the muscles, there may be a problem with the muscles itself. Genetic testing. So blood samples can be examined for mutations in some of the genes that causes types of muscular dystrophy. So in order to check for the genes, they will obtain blood samples from the patient. Muscle biopsy, it can be removed through incision with a hollow needle. Analysis of muscle tissue is going to be done to distinguish whether the patient has muscle dystrophy or other forms of muscular diseases. Heart monitoring tests such as ECG and echocardiogram. So they're going to check for the heart muscles, cardiac muscles, if they're still working well, since one of the complications of this would be problems with the heart, like what I've mentioned earlier. Lung monitoring tests if the respiratory muscles are already involved. So they are going to test the efficiency of the lungs now. Next would be electromyography. So an electrode needle is inserted to the muscle. So it's like ECG as well, but this time the electrical activity of the muscles is measured. So they are going to do this. So electrical activity is measured as the patient relaxes and as they gently tighten their muscles. Changes in the pattern of electrical activity can confirm a muscular disease. Treatment. Although there's no cure for muscular dystrophy, treatment of some forms of the disease can help extend the time of a person with the disease, and they can remain mobile and help with heart and lung muscle strength. There are also new trials that are being done, new therapies that are being done in order to improve the life of a patient who has muscular dystrophy. So patients who have this condition will be monitored throughout their lives, their whole lives. Their care team should include a neurologist with expertise in neuromuscular diseases, a physical medicine, and rehabilitation specialist, and physical and occupational therapists will be needed as well. Some people may need a pulmonologist if there are any lung complications, a cardiologist for heart complications, and an endocrinologist if there are anything that is involving the endocrine system of the patient, which is really rare. Orthopedic surgeon can also be consulted with regards to their bones, since the muscles, skeletal muscles, are attached to the bones. Treatment options include medications, physical and occupational therapy, surgical and other procedures, and ongoing assessments of walking, swallowing, breathing, hand function, which will enable the treatment team to adjust treatments as the disease progresses. So as the patient grows older, this disease progresses and it further worsens. Usually the prognosis of these type of people, they have a very short lifespan. And it is most unfortunate because some of them can die very young from this disease. And some patients may die during their teens and early 20s from this disease. That's the average. So medications, corticosteroids such as prednisone and Developmental and Plaza, they can help muscle strength and delay the progression of certain types of muscular dystrophy. But prolonged use of these drugs can cause weight gain and weaken bones, further increasing fracture risk. Newer drugs include eteplirsen or Exondys 51. This is the first medication that is approved by the FDA. This is used to treat some people with Duchenne muscular dystrophy. It was approved in 2016. This eteplirsen or Exondys 51. Last year, the FDA approved golodirsen or Vyondys 53 for some people who have Duchenne dystrophy. Heart medications such as ACE inhibitors and beta blockers are used if muscular dystrophy damages the heart. So what we do is we help with the range of motion and stretching exercises, since muscular dystrophy can restrict flexibility and mobility of the joints. So limbs often draw inward and become fixed in that position. So what we do is to help the patient with range of motion exercises to keep these joints flexible and as possible. Exercise, low impact aerobic exercises such as walking and swimming can help maintain strength, mobility, and general health. So this can be helpful if the patient can tolerate such activities. And it's important to talk to the physician first because some types of exercises can be harmful for the patient. Braces can also be used to keep the muscles and tendons stretched and flexible. This allows the progression of slowing down the progression of contractures. Braces can also aid mobility and function by providing support of the weakened muscles. If the patient has a trouble walking, Mobility aids such as canes, walkers, and wheelchairs can help maintain mobility and independence. So we are going to teach the patient how to use canes, walkers, and wheelchairs. So which foot comes up first when going up the stairs, which foot comes down first when going down the stairs with the use of a cane or a walker. So we should all know that. We have our MS lab for that one. Breathing assistance. As the respiratory muscles weaken, a sleep apnea device might help improve oxygen delivery during the night. Some people with severe muscular dystrophy need to use a machine that forces in and out of their lungs, such as the ventilator. So this is the end-of-life complication of patients with muscular dystrophy. They may need a breathing assistance later on if the respiratory muscles are already affected. And if they are going to need this, most probably the prognosis of the disease is going to worsen. And for our last topic, we have the Legg-Calve-Perthes disease. What is this? The Legg-Calve-Perthes disease is a childhood condition that occurs when blood supply to the femoral head of the hip is temporarily interrupted. So once that is interrupted, the bone begins to die. Since there is limited or interruption of blood supply. So this weakened bone gradually breaks apart, so it breaks off, and it will lose its round shape. Remember, the femoral head is round. So if blood supply has been interrupted, it can no longer, or the tendency is the bone will die, it will break off, and the round shape is gone. So the body eventually restores blood supply to the ball, and the ball heals. But if the ball is no longer round after it heals, it can cause pain and stiffness. So the complete process of bone death, fracture, and renewal can take several years. So keep the ball point or the ball part of the joint as round as possible. Doctors use a variety of treatments that keep it snug in the socket portion of the joint, and the socket acts as a mold for the fragmented femoral head as it heals, since the socket is circular in shape as well. So it will help mold the femoral head. So as you can see here, if blood supply is lost to the femoral head, that one breaks off. It will be flattened instead. Clinical manifestations. There's limping, of course, since the patient will have a hard time walking, so they will have a hard time. They will be having limping while walking. Pain or stiffness in the hip, groin, thigh, or knee of the affected hip joint or the affected femoral head, and limited range of motion of the hip joint. So they cannot abduct their hips, that is the hip that is affected, or the leg that is affected. Pain that worsens with activity and it improves with rest. So if they walk, let's say for example, they walk, they are going to experience pain. But this disappears when they rest. Legg-Calve-Perthes disease usually involves only one hip, so it's unilateral. Both hips are affected in some children, usually at different times. But usually this one is unilateral. So cause, again, just to summarize this, I've explained how this happens. The cause is unknown. Again, it is idiopathic. The description that I've told you earlier is that there is interrupted blood flow to the femoral head. That's why it weakens, it dies, it weakens, it breaks off. Risk factors. Although Legg-Calve-Perthes disease can affect children of nearly any age, it most commonly begins between the age of 4 and 10. So remember, it is common in children between the age of 4 and 10 years old. The child sex, Legg-Calve-Perthes is 4 times again more common in boys than in girls. So boys are more commonly afflicted with this disease. And with the race, white children are more likely to develop this disorder than black children. So it's more common in Caucasians. Genetic mutations for a small number of people like Legg-Calve-Perthes disease appears to be linked to mutations in certain genes, but more studies needed with regards to genetic mutations. Complications. Children who have had Legg-Calve-Perthes disease for a long time are at a higher risk to develop hip arthritis in adulthood, particularly if the hip joint heals in an abnormal shape. So it's not round in shape, it's irregularly shaped. So if the hip bones don't fit together well after healing, the joint can wear out easily. Remember, there's a cushion there, the cartilage that cushions the joints between the two bones. If it is irregularly shaped, it will wear out the cartilage that provides the cushion. In general, children who are diagnosed with Legg-Calve-Perthes after age 6 are more likely to develop hip problems later in life. The younger the child is at the time of the diagnosis, the better the chances for the hip to heal in a normal round shape. Since the bones of younger children are more flexible than older ones. But if this has developed in an older children, they are more likely to develop arthritis in adulthood. Diagnosis, x-rays are going to be used. It might look normal because it can take 1 to 2 months after symptoms begin for the changes associated with Legg-Calve-Perthes disease to become evident on the x-ray. So they will recommend several x-rays over time to track the progression of this disease. So not only a single x-ray will be done on the patient. MRIs will also be used in order to check the bone and soft tissue of the body. And take note, our nursing responsibility when MRIs are done is to remove any metallic object on the patient's body, such as jewelry, remove the stretcher, the wheelchair from the MRI room before the MRI diagnostic procedure is going to begin, since this involves a strong magnet in order to visualize the internal organs of the body. So those are our nursing responsibilities. Treatment in Legg-Calve-Perthes disease, the complete process of bone death, fracture, and renewal can take several years, so it will depend on the age when the symptoms began, stage of the disease as well, and the amount of hip damage. As Legg-Calve-Perthes disease progresses, the ball part of the joint, the femoral head, weakens and fragments. So during healing, the socket part of the joint can serve as a mold to help the fragmented femoral head retain its round shape. So for this molding to work, the femoral head should remain inside the socket. So a leg cast, again, a hip spica cast, similar to the one to DDH, will be placed on the child. So the legs will be widely spread apart for around 4 to 6 weeks while that cast is applied. So hip spica cast is done again. Our nursing responsibilities for the hip spica cast is also similar for a patient who has Legg-Calve-Perthes disease. Some children may require surgery to keep the ball of the joint snug within the socket. So this might involve making wedge-shaped cuts in the thigh bone or the pelvis to realign the joints. Usually, for children who are younger than 6, surgery is not needed since the socket is naturally more moldable, so the ball and socket typically continue to fit together well without surgery. If the child, take note, is younger than 6, but if the child is older than 6, then maybe they will be needing surgery for this, or a cast. Activity restrictions. So no jumping, running, or other high impact activities that will accelerate the hip damage. They need to rest while the bone heals. Crutches may be needed in some cases. The child may need to avoid bearing weight on the affected hip. So we need to teach the patient how to use crutches. That is one of our nursing responsibilities. How to walk with crutches. You will learn that in your RLE skills lab on how to use the different ways to use crutches. The swing through, the swing to, and so on. Physical therapy. So as the hip stiffens, the muscles and ligaments around it may shorten. So stretching exercises can help keep the hip more flexible. So we need to refer the patient to physical therapists. And anti-inflammatory medications can also be helpful if there is pain felt by the child, such as ibuprofen or even naproxen sodium can also be used. These are NSAIDs. So that's it for the congenital disorders of the skeletal system. If you have any questions with regards to my lecture today, please do not hesitate to message me. I will reply to you as soon as I can. And wait for our next lecture here for orthopedic nursing with regards to the different types of arthritis. Thank you and have a great day.